Medi loners. Now let's start pathology of stomach. Gastropathy and acute gastritis. Patient will come to doctor with following symptoms: number 1 epigastric pain, number 2 nausea and vomiting, number 3 in severe cases hematemesis and melena. Inflammation of gastric mucosa is called acute gastritis if neutrophils are present, but gastropathy if neutrophils are absent. Pathogenesis: gastric lumen has pH equal to 1. Stomach has several protective mechanisms to protect itself. These protective mechanisms include surface mucus and bicarbonate secretion, epithelial barrier function, epithelial regenerative capacity, elaboration of prostaglandins, mucosal blood flow. When damaging forces become greater than protective mechanisms, then gastropathy and gastritis will occur. These damaging forces are NSAIDs. They will inhibit cyclooxygenase, then COX-dependent production of prostaglandins E2 and I2 will not occur. Prostaglandins contribute in all defense mechanisms discussed earlier: reduced mucin and bicarbonate secretion, for example. In old age, reduced oxygen delivery. It happens mostly at high altitudes. Inhibition of gastric bicarbonate transporter. Pylori has urease enzyme which converts urea into ammonium ions. Uremic patients also produce ammonium ions. Ammonium ions inhibit gastric bicarbonate transporters. Direct cellular injury. Direct cellular injury of epithelial cells is caused by alcohol consumption and tobacco, etc. Morphology. Gastropathy and mild acute gastritis. Surface epithelium is intact, but there is foveolar cell hyperplasia with characteristic corkscrew profile. Epithelial proliferation. Neutrophils are present in epithelial cells and lumen of mucosal glands. As the disease progresses, superficial mucosal defects, that is erosions, are seen. Neutrophilic infiltrates and fibrin-containing exudates are present in lumen. Dark puncta caused by hemorrhage are present within hyperemic mucosa. Concurrent erosion and hemorrhage is called acute erosive hemorrhagic gastritis. Next topic is chronic gastritis. Causes of chronic gastritis: H. pylori infection, autoimmune gastritis, radiation injury, indwelling nasogastric tube, chronic bile reflux. H. pylori gastritis. H. pylori are spiral/curved bacilli. 100% cases of duodenal ulcers are associated with H. pylori. Most of cases of gastric ulcers are also associated with H. pylori. Pathogenesis: when inflammation remains limited to antrum, increased local gastrin production occurs. Parietal cell hyperplasia and increased acid production occurs. Increased risk of gastric/duodenal peptic ulcers. Long-standing H. pylori gastritis involve gastric body and fundus leading to reduced parietal cell mass and intestinal metaplasia leading to patchy atrophic gastritis leading to reduced acid secretion and increased gastrin production. As a result, remaining parietal cells secrete limited acid leading to reduced risk of gastric/duodenal ulcers and adenocarcinoma. How does H. pylori causes all this? Due to its virulence factors: 1. Flagella, which offers bacterial motility in viscous mucus. 2. Adhesins enhance bacterial adherence to foveolar cells. 3. Urease converts urea to ammonia, which increases gastric pH and promote bacterial survival for toxins, for example CAGA. Let's study morphology. H. pylori is found in stomach by biopsy. Most common site to perform biopsy is gastric. Antrum organism is present on superficial mucus overlying epithelial cells. Gross appearance of H. pylori infected gastric mucosa is erythematous and coarse or nodular. Microscopic findings: inflammatory infiltrates in lamina propria. Large number of plasma cells, often in clusters/sheets within superficial lamina propria. Large number of neutrophils/lymphocytes/macrophages are also found. 2. Across basement membrane. Neutrophils accumulate along the basement membrane. Neutrophils create pit abscesses by accumulating in lumen amp, pits of gastric glands. In severe cases, inflammatory infiltrates may create thickened rugal folds which may look like cancer. Lymphoid aggregates, some with germinal centers, are present and represent as malt mucosa-associated lymphoid tissue which has potential to transform into lymphoma. Diagnostic tests: biopsy, serology for antibodies for H. pylori, fecal bacterial detection, urea breath test. Tests performed on biopsies include rapid urease test, bacterial culture, PCR treatment, combination of PPI and antibiotics. Autoimmune atrophic gastritis. Autoimmune atrophic gastritis is characterized by antibodies against parietal cells, an intrinsic factor that can be detected in serum and gastric secretions. Reduced serum pepsinogen 1 secretion, endocrine cell hyperplasia, vitamin B12 deficiency, defective gastric acid secretion, achlorhydria. It typically spares antrum and present with hypergastrinemia. Pathogenesis CD4 plus T cells directed against parietal cell components including hydrogen potassium ATPase leading to loss of parietal cells which lead to loss of gastric acid which stimulate gastrin release leading to hypergastrinemia and hyperplasia of antral gastrin producing G cells. Loss of intrinsic factor leads to defective ileal vitamin B12 absorption leading to vitamin B12 deficiency and pernicious anemia. Morphology: thin doxyntic mucosa of body and fundus due to diffuse atrophy. Rubal folds are lost. Nuclear enlargement within epithelial cells due to vitamin B12 deficiency. Inflammatory infiltrate composed of lymphocytes, macrophages and plasma cells. Inflammation is deeper and centered on gastric glands. Glandular atrophy can be extensive. Residual islands of oxyntic mucosa give the appearance of multiple small polyps and nodules. Intestinal metaplasia with presence of goblet cells is present. Endocrine and enterochromaffin-like hyperplasia is also seen. Clinical features: 1. Atrophic glossitis, 2. Epithelial megablastosis, 3. Malabsorptive diarrhea for bone marrow and CNS changes. Subacute degeneration of spinal cord.